Jim Ondick is a childhood cancer survivor, and that cancer cost him his left eye. Decades later, he had cancer again, now in his brain and lungs. We share the treatment and science behind his survival. Good morning, I'm Alexis Del Cid. Welcome to a new season of All Things Brain Health. Today we share an extraordinary medical journey from childhood cancer to stage 4 metastatic melanoma that spread to his brain and his lungs, and now promising immunotherapy. Jessica Lovell shows us.
Jim Ondick is no stranger to challenges. At just 6 months old, he was diagnosed with bilateral retinoblastoma, a rare childhood eye cancer. But like all of us, his childhood was all he knew.
I mean, you go through all the same things like that, other kids and stuff go through of like, trying to fit in and stuff like that. And you just, to some extent, like you don't, because you just don't like look the same as everybody else.
That's because when Jim was just 2, to remove part of the cancer, they had to remove Jim's left eye.
Early on, they took the left eye, but then they still thought that with all the radiation that I received, that there was going to be some diminished sight in the remaining eye. And so there was always that kind of like cloud hanging over of like, how much vision am I going to have? Like, am I going to be able to drive and all that kind of stuff? And like, none of that really came to be a problem.
He could drive, but he had hoped to join the military one day. But his vision kept him from that dream. So he soldiered on, going to college, where he met his now wife, Bridget, and would eventually find work in the tech sector. It was life and business as usual through most of his 20s, until he noticed something.
I had a mole that was right here, and it just kind of felt wrong. It was kind of, hard and kind of itchy. Like they tell you now, like, obviously pretty well versed in this stuff, like anything that changes is bad. And so I went and saw a dermatologist.
Doctors performed a biopsy, removed the spot, and cleared the margins. Jim continued regular skin checkups. That was in 2011. Then, in 2015, a new set of symptoms popped up.
I started having some swelling, so my knees were getting swollen, like down through my calves, and like my feet especially were getting pretty swollen. And then I was having chest pain intermittently.
A year would go by. Jim's daughter Mara was born. He even ran a 5K. Symptoms were still coming and going, but it all came to a head when Jim got so sick one night, doctors ordered an MRI. Testing showed Jim's cancer from 2011 had spread. It was now stage 4 metastatic melanoma. He was referred to the University of Kansas Cancer Center.
So there's a tumor on the cerebellum at the back of my head, and then there was all this, so it's called your mediastinum. It's basically all your connective tissue from your throat, like all the way down that connects your lungs. There was a huge mass all the way through this, and then there was a nodule in the lung. This is what was causing all that pain that I was having in my chest.
Doctors surgically removed Jim's tumor the next day. He spent a week in inpatient rehab. He thought about his baby daughter, not knowing what was next.
I'm writing letters to her, because I'm assuming that I'm not going to be around, to tell her some of these things that I want her to know.
He started radiation and infusion treatments, but Jim experienced a life-threatening setback.
Sometimes those can start attacking healthy cells too. And so that's what basically was happening. My body's kind of like imploding. My immune system's trying to kill me.
Jim had developed hemophagocytic syndrome from the treatment.
I'm driving home, I'm thinking it's not even going to be the cancer that's going to get me. It's going to be this.
It was deadly, but miraculously, as the medications started to fade from his body, so did the syndrome.
Those just kind of run out, apparently, and the thing just resolves itself. It just went away.
And just like that, Jim was back to treating the cancer. His oncologist, Dr. Gary Doolittle, started him on another type of treatment, a combination oral immunotherapy. Jim has responded so well, he is now considered what's called NED, no evidence of disease.
So I'm very cognizant of the fact that this has gone really well, but it doesn't mean that it will still. It could stop. This ride could end. It could come back at some point.
For now, Jim takes nothing for granted. And in a full circle moment, and with all the time he has spent here, Jim now works at the University of Kansas Health System, working hard for the two people he loves the most.
Spending time with her and teaching her how to do certain things and get to know her, like just this wonderful little girl that she is.
What a perfect family. How old is Mara now?
She's 9.
How old is she?
9.
9 years old. She's so cute. Oh my goodness. Jim Ondick is here in the studio with us today. Thank you for being here. Alongside his medical oncologist, Dr. Gary Doolittle. Thank you so much for taking the time to join the discussion. Jim, how are you feeling today?
Really good. I'm just super excited to tell this story, talk about the people who took care of me and got me where I am today.
And what do you do here at the health system?
So I'm an IT business partner in our Health Information Technology Services.
So you're the one we're always calling frantically from the newsroom here when something goes wrong.
Yeah, not quite.
Thank you for everything IT does, though.
Yeah.
The backbone of any business is IT. The brain, Jim, has an amazing ability to adapt. In your case, it started very young with you losing sight in your left eye. Do you have, and what memories, if any, do you have of when you lost vision? You were so young.
Yeah, I don't know that I ever had a memory of before that time. So just always just kind of going along with, adapting.
Right, as you've said, you only know what you know.
Right.
Did it affect any milestones in your life, like getting a driver's license?
It did. It was, I think, an additional check that I had to go through with vision. I was being seen regularly by ophthalmology at the time, and looking at that and like, do I have good enough vision to be able to drive? And then how does that lack of peripheral vision affect driving?
Right. How does it? I was always wondering that.
You probably noticed just with me looking at you now, kind of my head's kind of always like tilted just a little bit to the side.
Because you don't have vision in your left eye,
yep.
right?
Yeah, so 180 degrees of peripheral vision just kind of shifts a little bit.
Okay.
Yeah.
But you're still able to do everything that you normally did. You had a childhood that was what you knew. Did you play sports? What sports did you play?
Anything with a small ball that's moving quickly. It probably didn't go as well. You talked to some of my high school friends about that.
What would they tell you?
That didn't go well.
Yeah.
So, but no, I didn't play any. I think I played basketball, grade school, but nothing big like that.
Dr. Doolittle, Jim had bilateral retinoblastoma as an infant. How do you explain that to parents without a medical background?
Right. So that's probably the biggest challenge for any oncologist is educating the patient in a way that they can receive the material. And a lot of it, it's not rocket science. If we choose the right words and we spend the right amount of time, most patients will be able to understand exactly what's going on. In a setting like Jim's, he had a cancer that was related to an abnormal gene called retinoblastoma 1. And so we would sit down and say, we've got this gene that's abnormal, and that's what's causing the cancer. And then we'd walk through the steps of how we're going to approach it. So many cancers are due to some kind of gene problem within a cell. And it's either a gene that turns on and causes that cell to grow too much and doesn't shut the growth down and you get cancer. Right. Or it's a gene like Jim had, the retinoblastoma gene, where it makes a protein that shuts down growth. If you lose that gene and you lose that protein, the ability to shut down the growth is lost and you get abnormal growth in the tumor. It takes time. And I even tell patients, if you get 30% of what I'm talking about today, you're doing great. And then next time we talk, you're going to get another 30 to 40, and we're just going to keep talking, and the terms are going to be familiar to you. But patients can understand this. It's the right words and the right amount of time to make it happen.
The bedside manner.
Absolutely.
And I could see it right away that you both have a bond with each other.
Yeah, I grew up with Jim. Sort of.
Tell me about that.
Well, Jim came into melanoma at a time when we had just had so many new agents. And it was such an exciting time, still is, But we didn't know, we knew about side effects of the agents, but we didn't know what the long-term outcomes were going to be with these drugs.
When you say agents, you mean medications?
Yes, and two different types for Jim. One was immunotherapy, where we give drugs that stimulate the body's immune cells to fight the cancer. And the other is targeted therapy, drugs that neutralize a particular protein that's causing abnormal growth. That may be more than you wanted to hear, Alexis, but
you do a good job of explaining.
It's this whole field of targeted therapy, and it's wildly exciting because, literally each week we're getting new drugs that are coming to the market in the cancer space that are making huge differences in our outcomes. So when I say we grew up together, we'd only had agents that actually kind of worked for 3 or 4 years when Jim was diagnosed. So it was like exciting, but also very nerve-wracking at the same time.
Well, you described Jim when Dr. Doolittle came in. He said, "You got to know Jim is a medical miracle."
Mm-hmm. No, I think so, because if I'd met Jim 4 years earlier, I don't think he would have survived it. So,
wow.
And I don't know. I want to know what you say about this. I don't think you had the easiest run for a long time there.
No, the first year was a little rocky, and I made the mistake of looking at the survival statistics.
Oh boy.
And the 5-year was maybe like 20%. I think the 10-year was like 5. It was low.
Right.
So.
Did you and your wife both look at those?
No, I don't think I showed them to her.
Because doctors always say, don't Google it or don't look up on the internet. Let's trust me. But it's
impossible.
Yeah, I would have done the same thing.
Yeah.
So how did you handle that?
You kind of have to hand it over, I think, at a certain point. And what I mean by that is faith is kind of just where it comes into play. And it's not something I control. So.
Right. You just say, this is happening.
Yep.
And hand it over. And these pictures of you with your little girl, who's now 9, are just precious. When we talk about Jim's journey, the cancer then spread to the cerebellum, which is sometimes called the little brain. Why is the cerebellum called that? And can you point for again, our non-medical audience, where is the cerebellum?
Right. I'm not, as a non-neurosurgeon, non-neurologist, I should be staying in my lane, but this one I can answer.
Okay, thank you, thank you.
It sits more at the base of the brain. You have two areas called the cortex, and the cerebellum sits behind and in the base. And if you actually look at it, it looks like a little brain. And it's really all about motor and coordination, kind of your center for motor and coordination. And that's why when Jim presented, he had symptoms that were consistent with disease in the cerebellum.
That was my next question. What were the symptoms?
So I had done that 5K at the Kansas City Marathon.
Right.
And I went to bed that night fine. And the next night I laid down and the room just started spinning. And so there's this terrible vertigo. Yeah.
And that led you to the doctor, which led you to that diagnosis.
Eventually, yeah. It took about a week to kind of figure things out. They thought I had an inner ear thing for a minute.
Sure.
And then eventually got to get the MRI and figure out what was really happening.
Are there any theories, doctor, behind why Jim developed that brain cancer after being treated for the retinoblastoma?
Yeah. When he first presented and the mass was in the cerebellum, for an individual that has the retinoblastoma gene problem, primary brain tumors can be associated with it. Other types of cancer, osteosarcoma, soft tissue cancers can be associated with it. So even in reading the first physician's notes, one of the things they worried about was this a tumor that started in the brain, or is this a tumor that started someplace else and spread in the brain? Well, as Jim could really articulate to you, melanoma is also one of the diseases that we see in people that have the retinoblastoma gene problem. So he'd had the melanoma, and it really wasn't the treatment, I don't believe, or prior radiation that caused this. The retinoblastoma put him at risk for melanoma. He got it treated properly, but it recurred. And when it popped up in the brain. And as your description was beautiful of the mediastinum, right? Because he had real big, bulky disease in the middle of the chest.
Oh, gosh. So. How big was it? Do you know? Like if you had to,
I'll go like this.
like
Yeah, it was huge.
like a large softball.
Yes.
And you're not a big guy. You're not a small guy, but where would that even go? A large softball. You're a runner.
I think that's kind of where it came into play in the latter part of 2017, is that it was starting to take the place of other things that needed to be there.
Right.
Like my ability to breathe.
And what I mean by not a big guy, no guy wants to hear that. I mean, you're trim. You're not built like a linebacker. You're built like a runner. So when I hear there was a softball-sized thing in your chest, it's like, where would that go? What would that do? So when cancer spreads to the brain, how does that change how you treat the cancer, Dr. Doolittle?
Right. Good question. You triage at the beginning. What's the most difficult problem we have to manage? And for Jim, it was really the tumor in the brain. Even though this was a problem and it was big, he could tell you by the symptoms that he was having that we're going to have to address the brain first. And that's where Dr. Shamoon came in and actually removed the tumor from the cerebellum, first line, and then radiation after that in the lining of where the tumor was to deal with that, because it's classic, right? He's got a tumor in the brain, and even the smallest bit of growth makes a lot of symptoms worse. Mm-hmm. So that was the first thing. I can't believe you spent a week in rehab, because most people, if that were me, I'd be in there for 2 or 3 or 4, but in and out in a week.
Do you think it was because he's a runner and he was in such great shape?
I think it was because he's young and healthy, right? Yeah. You're young and healthy. And as long as I've known Jim, I've never really considered him sick in the way that he acts, right? That's not how he acts.
What a compliment.
But I can see a week of, rehab, and then we got to move on. We've got to take care of the disease that's elsewhere in the body.
And we should tell our viewers, Dr. Shamoon was also scheduled to be on this show and answer all of our brain questions. But as you know, doctors are very busy. They often get called away for things. So unfortunately, he couldn't join us this morning. But Dr. Doolittle, you're doing a great job.
I'm not in my lane, so I'm trying to be careful, people.
You're doing a great job. You're more in a lane than I would be answering these questions. Jim, you're now considered NED, which means no evidence of disease. What's the difference between no evidence of disease and cured?
Yeah, that's a really tough question in melanoma, because all the way through my training and really through the last 30 years, it's been very hard for the melanoma community of physicians and practitioners to tell a patient with melanoma they're cured. And the reason for that is it can have late recurrences. Jim knows that. I mean, it's like, I'm still processing, every day's here and this is great. You can have late recurrences, and then we never had treatments that worked that well. We never had patients that went into remission like Jim has. And so once that happens, we're kind of startled by it, thrilled by it, but we're always kind of anxious about if something's going to recur down the line. I think what Jim has going in his favor is he's had years where he's had no evidence of disease, and more we're seeing this. I have a large cadre of patients now that had metastatic disease that had spread to the brain, and we've been able to treat it. We've been able to treat disease outside of the brain, and they've had prolonged periods where they're in remission. I think we're getting ready to use that 4-letter word, cure. Oh, melanoma docs don't like to use that word because it's just, we don't have enough history with it. And even 10 years in the history of these drugs, we're at the 15-year mark for the one drug like Yervoy that you got. 15 years ago in March that came to the market.
What an evolution. Of science and medicine. And speaking of evolution, we have some general video, not of Jim. This is of someone undergoing radiation. But what I want to ask is, you had radiation as a child, then as an adult. What do you remember differently about the experience from the time it evolved?
So I think I was so little that all I remember as a baby was being like, it was a beanbag that they had to like strap you into. Oh. Not a fan. That wasn't my favorite.
And now that you had a baby of your own and you have a little girl, when you look at her, does that change your perspective a little bit?
Yeah, that was probably one of my focus areas because this happened. My surgery was just 3 days short of a month after she was born, So she was born 9/29 and my surgery was 10/26. So it all came all at the same time, basically. And so that, yeah.
But she's so healthy.
She is, yeah, she's great.
When you look at her and think what you went through by the time you were 9,
yeah,
it must feel, you must just want to wrap your arms around her all the time and be so thankful that she doesn't have that same journey.
very much so,
Yeah.
yes.
You were at one point writing letters to your daughter, Mara. Is it Mara or Mara?
Mara?
Mara, okay. So you're writing letters to your baby because you thought you might not be around to raise her. Are you comfortable sharing any of the things you wrote to her?
I was just trying to tell her certain things I wanted her to know, more about me than anything else. Thinking, my mind always went to the events in her life that I was going to miss, and thinking of, her first communion, or her getting married, or graduating from college, or all these things wherever her life takes her, and just wanting her to know as much as she could about me, and that I was proud of her wherever she was.
And now she knows that because she's experiencing it.
Yeah.
She's 9 years old. Did you save the letters?
No, I couldn't keep them.
Right.
Yeah.
I wouldn't want to save them either.
Yeah.
But how beautiful she gets to experience you
Yeah.
in the flesh. We have some really nice questions coming in. If you have anything you'd like us to ask Jim or Dr. Doolittle, or you'd like us to share as a comment on our program, you can just send it to us on YouTube or Facebook. The links are right there on your screen. Dr. Doolittle, the cerebellum controls balance and coordination. So when operating on the cerebellum, are you comfortable talking about the major risks?
Sure. I mean, I would talk to you as a medical oncologist, non-surgeon, about the major risk, and usually it comes back to the symptoms that you present with, right? So the trouble that Jim was having, the worry is that even going in and removing the cancerous tissue, you will damage tissue around that area, and the symptoms will persist or not get better or have something new neurologically happen. The skills of a neurosurgeon still to this day amaze me, and the outcomes that they have, and how often the outcomes are so positive. But every neurosurgeon would have gone in and told Jim, I may not be able to fix this, or you may come out with neurologic symptoms that are even worse. And it's scary enough.
Of course.
But in order for a patient to be fully informed, you've got to let them know that the work we're doing here may not help, or it could make things worse.
Dr. Doolittle, Jim developed this rare but life-threatening condition during his treatment. It was some sort of immune reaction, which sounds terrifying. You're driving thinking, I made it this far, and now this is going to get me. It didn't, thank God. How do you explain how it went away?
Right. Actually, it was called hemophagocytic syndrome, which you mentioned earlier in the clip, and the challenge with that was it could have been due to the immunotherapy that he'd had, because at that point he'd had a couple of cycles of immunotherapy. But we'd also switched out to pills. This is what I'm talking about, the targeted agents. And the pills actually work really well in melanoma. 65 to 70% of patients do really well. And Jim had horrible disease in his chest, could hardly lie flat, was coughing nonstop. Put him on the pills and he was improving. Quickly, he started to improve. Well, the challenge was, did the hemophagocytic syndrome, was that caused by the immunotherapy he'd already had, or are these pills triggering it? And he needs the pills. And frankly, he needed the immunotherapy too. He did see one of my colleagues, Dr. Mark Hoffman, very astute, picked up the fact that this was hemophagocytic syndrome. You did get a steroid in there for about 4 days. And that probably was enough to tip it over such that it was going to resolve and settle down. Thank God it did, because it enabled Jim to continue to have therapy. And even now, it's reported with both immunotherapy and targeted therapy. But when it happened, they were given to Jim so quickly together, we didn't know which one did it.
You just were throwing everything at him.
I thought it was the immunotherapy because he'd had a couple cycles, and mechanistically it made sense to me that it was. But it could have been the pills, and I really wanted him to get the pills.
Yes.
He really needed them with his bulky disease in the chest. So It was a, doctors don't like to tell people they're scared too often. Hi, I'm your doctor and I'm scared.
Right.
This one kept me awake at night for a few nights until things settled down.
So you were at home.
Oh yeah,
this was,
and the whole team I work with,
wow.
The nurse practitioners, the nurses I work with, we all were very aware of how sick Jim was, and it was a nerve-wracking time. For us, it's nerve-wracking. For you were having really tough symptoms, and that's what I mean when I say I'm not sure you're going to get the full story out of this guy.
Yeah.
It was a rough period in there, and boy, what grace and dignity,
Such strength. Well, Dr. Doolittle was saying, Jim, he never thought of, you were very sick, but you never presented as super, super sick emotionally. You just kept moving forward. I want to get real quick, before we get to community questions, I want to mention your work with Braden's Hope. It's a nonprofit that helps support childhood cancer. How did you get involved with Braden's Hope?
So I got introduced to one of their directors, Kim Stanley, through a friend of a friend. And Kim's daughter, Callan, had the same retinoblastoma as a child as I did. And so we just kind of hit it off through that. And I've been on their advisory board ever since, trying to help in some way, however I can. And it makes me think of like what Dr. Doolittle said of all the options that we have for treating cancer now. And we look at pediatric cancer is kind of overlooked in some ways. They're not just small adults. And that's what I think Braden's Hope is trying to change, and that was something that resonated with me.
That's really important work that you're doing. We do have a community question from Becca, so let's get to some of the questions for our viewers. This is a great one. Becca wants to know how you handle the what ifs now. And she shares, I have a friend who's in remission who feels quite anxious. How do you do it?
I mean, it comes back to a faith thing. Like, I don't have a new answer, I guess, but that's really where I think I go back to and realize that that's kind of how I got through all this in the first place, and it worked. So
letting go.
Yeah.
Lauren has a question for you, Jim. She wants to know, she writes, I would like to know more about your childhood, Jim. Did not having an eye affect you socially or emotionally?
It did. I mean, like when we're kids, the only thing you want is to fit in, right, and just be like everybody else. And like I said, that wasn't the case. It wasn't going to happen. But I had a lot of friends that it just didn't care, and I think it just highlights those relationships and just makes that even better than that way.
Those are the friends you have for your whole life.
Yeah.
Denise wants to know, what have you learned about your health as far as if it's genetic?
So the RB1 mutation was something that presented spontaneously, from what I understand. I don't have anyone else in my family that has that. As far as the melanoma, I don't know if that was genetic or not. I have a relative on both sides that had it. So Dr. Doolittle would probably talk more to that than me.
Is there genetic testing he could do?
There is genetic testing, and actually had done, and for his particular cancer, the cancer gene was checked. The melanoma there's a higher incidence of melanoma in people that have had retinoblastoma. So we know there's this genetic component to it when we see a higher incidence like that. It is confusing for a lot of patients. We talk about genes that you inherit from your parents, and everyone thinks of that as genetic, right? And it is. But then we talk about genes that are causing cancer, and sometimes those are not genes that your parents gave you. One of the cells in your body changes, it mutates. In this case, the retinoblastoma gene mutates, and it can no longer function like it does, and it's in the retinal cells of the eye. So there's this genetic predisposition from parents, and then there's the medical jargon is somatic, or gene changes that occur in other areas of the body that gene change you did not get from your parent. So it's really hard right now. We're really trying to figure out our best way, because that world is exploding.
Sure.
Identifying genes that are associated with certain cancers that may be inheritable, that is just, I wouldn't be able to practice without amazing genetics counselors that we have.
We
at
love
KU.
interviewing our genetics
They
team,
are
the
amazing right
counselors.
now.
For today's takeaways, I want to start with you, Jim. What do you wish more people knew who are watching?
So I hear the fight, like, oh, thinking of kind of fighting cancer, and I don't know that I ever thought of myself like this warrior that was going through these things. I think I look more at my wife, who was raising an infant at the time, and everything that she did to take care of both of us through that period of time, and then the cancer team that I had that supported me, the nurses that were in the infusion centers, the nurses that helped me through radiation, all these people that come together to make all this happen, and really focus on that as opposed to me looking at what I did or myself. And I mean, I think sometimes my struggle was just getting up that day, and if I could do that, then I was in good shape. But I think I'd like to flip the narrative to them.
That's so gracious. Dr. Doolittle.
That's Jim.
Yeah.
I would tell you that there's so many advances in oncology, and for those that are part of our trainee program, I just always emphasize, oh my gosh, you're coming into this at an amazing time. And even though it's a really frightening diagnosis, I mean, everyone knows about cancer, everyone's had a friend or family member that has had cancer, and it's very frightening. There's so many new advances, and they're coming at us like at warp speed. And try to avoid, the friends that say you should try this or get on this website, they'll tell you how to treat your cancer. Try to avoid that until you at least get that first or second opinion, and then start your information journey. Because there's a lot of good information out there.
It's exciting. It's an exciting time. Thank you for taking the time out of your day to join us.
My pleasure.
And Jim, thank you for sharing your journey with us. And to our viewers, thank you for joining the conversation. Coming up tomorrow, burn injuries. They can happen in a flash. Ezra Crutchfield was enjoying a bonfire with friends when a gas can exploded. It changed his life. On Wednesday tomorrow, learn about Ezra's journey and the treatments that help burn patients now heal faster and get home sooner.